Welcome everybody, I'm Michelle Walder. I have just hit my microphone, apologies, and I'm chair at the Migraine Trust, and it's a real pleasure to welcome you to our patient day. The meeting so far has been truly exceptional. People have had a great few days, and it's always a particular highlight for us and the team and the trustees to welcome everybody to the patient day. So thank you for coming. We've got an afternoon packed for you, hopefully, with information, some knowledge sharing, and also a patient perspective. So we've got 3 headache and migraine experts to come to talk to us, and then a patient as well. QR code here, if you haven't already clicked onto it. Take a photo, and it will take you to a place where you can put questions. We will do our best to answer as many as we can. We won't be able to get to all of them because there's already 22 questions on there. So we love the questions, and hopefully we'll find a way to pick them up in information services going forward. But please do pop them on there because it's really important that we understand what you as the patient group want to hear about and want to know about so we can tailor our content and make it really relevant for you. There will be an email coming out to you at the end of the day, pretty much, hopefully it should be there when you get home, which is got a link to a survey, hopefully 2 minutes, 3 minutes of your time. We would really appreciate it. It helps us, again, tailor everything, get your feedback so we can make the day as relevant as we can for you. And it will also have a link to register, which is also on the website, for a Q&A with Professor Peter Goadsby on the 16th of October, which is a great opportunity to get some expert knowledge at the same time. And with no further ado, I will hand over to our first speaker, who is joining us from the Netherlands today. Professor Gisela Terwindt is going to talk to us about a topic very close to my heart, being a woman of a certain age, hormones and migraine. Please, welcome, thank you.
I first would like to thank you for inviting me to speak here. I'm really honored to speak to you on this patient day. I also heard that there are many people online, so I also would like to welcome the people that are listening and not physically here. And I will talk about sex-specific issues in the treatment of migraine. And this is, of course, not my own work, but it's the work of the whole group at the Leiden University Medical Center. These are my disclosures, which I always have to show. Why are sex differences in migraine important? Well, as you might know, women are more likely to experience migraine than men. So there are 3 times more often women experience migraine than males. And 1 out of 3 women will suffer from migraine during lifetime. It doesn't mean that all these women will go to a doctor or that they are severely affected. Some of them are in their, what I say, happy denial, like me. But it's about the women that are really troubled by the migraine attacks. So taking that into consideration, I want to show you a picture of my daughter when she was 14, and she's hardly recognizable because she's in the middle somewhere. And I took this picture, and then I realized 1 out of 3 of these young females will develop migraine during lifetime. I realized that even before I knew that my daughter herself would develop migraines. So she's one of the 3 women in this picture that will develop migraine in life. What's the reason why people develop migraine in life? And I want to explain this very difficult schematic drawing, but I will take you through it. So our hypothesis is that the threshold to get a migraine attack is higher in a healthy, what we could call a healthy control, and a migraine patient, as you can see here. And this threshold is determined most importantly by genetic factors. So when your father or mother or other family members suffer from migraine, it's more likely that your threshold is low due to genetic factors, and with that you're more prone to get migraine attacks. Furthermore, there are other intrinsic factors, like for instance the menstruation period, and I will come to that later. So hormonal changes make your threshold fluctuate. So as you can see here, there is a dip in your threshold when you have your menstruation, and with that it's more likely that you go over this threshold and get a migraine attack. And for migraine patients, this threshold is lower than for healthy controls. Still, this doesn't explain why you might have attacks at a certain moment and at other moments you don't have attacks. So there are also other external factors that make you more prone to get an attack. This is again in this picture. So the intrinsic threshold for the migraine patient, you can see it's still fluctuating. It's lowered by genetic factors, but fluctuating with, for instance, the menstruation period, as you can see here. But also external factors, like for instance, drinking wine or being sleep deprived, make you more prone to go over this threshold. So if you're sleep deprived and you drank some wine, the susceptibility to go over this threshold is higher. So you're more likely to get an attack. And one of the hypotheses that is providing the contraceptive pill will lower your likelihood to get over this threshold and get an attack. So just shortly, how is it with the genetic factors? I talked about genes, I think 2 or 4 years ago, also at the patient day. So we know from all kinds of research that we did in Leiden with a large international headache genetic consortium that there are multiple genes implicated. So when you are migraine patients, there's not one gene implicated in your family, but we know now that more than 123 positions on the DNA, on the genetic chromosomes, are implicated in migraine patients. So there's no use of genetic testing for common migraine patients, but it's likely that there are multiple genetic factors involved in transmitting your migraine to your offspring. So with that, when my daughter had migraine, it was probably also due to the fact that I am in happy denial of my own attacks. So she is, what I will say, the genetics is not as good as we hoped it would be due to my own genetic profile. But again, there is another important factor which I would like to discuss with you today, and that's the menstruation period. So during the menstruation period, many women report having more attacks. We did a large cross-sectional study in, as you can see, almost 6,000 women and 1,000 males that are in our database with the migraine, and we asked about trigger factors. And as you can see, menstruation is one of the most reported trigger factors, but also stress, bright light, sleep deprivation, skipping meals, alcoholic drinks, and weather changes are all mentioned as trigger factors. So now I come back to my daughter, because she developed migraine when she was 16, and when she was 18, she started to study biology. And she said to me, I'm going to Leiden, I'm going to leave the home, I'm going to have a great student life, and you cannot stop me. And I thought, well, she will probably have sleep deprivation, she will be skipping meals, she will drink alcohol, she will eat certain foods that I normally would not provide, so this is a really bad idea. And this is one of the pictures of her. She didn't, I didn't ask her whether I was able to show it, but I won't pick to you where she is on this picture. But this is her fraternity or sorority group. So you can imagine that as a mother, I was really anxious and afraid with her attacks. And I always said to her, yeah, you had your attacks because you drank too much, or you had your menstruation, or you skipped meals. So it was really difficult for me as a mother not to say to her that she didn't do the right things. And I will come back to her later. Because we know also in women that when we treat them with the triptans, that it's more likely that they have a recurrence. And this is an explanation what a recurrence is. So normally your attack would be from the start, and in the dotted line you can see it ends at, for instance, after 20 hours. But now we provide you with a triptan as a patient, or a D10 acute treatment, and your attack is resolved. And most often there is some remaining headache, but the severity of the attack has been resolved. Many women experience what we call a recurrence. And this recurrence often occurs the next day when you wake up again, or sometimes even during the same day. And you have to take another tablet of a triptan or whatever. So we know that there is a huge difference between men and women concerning the acute treatment. So there's a similar headache response. Women report more side effects, which is quite logical because women are not as tall as men, so the dosage in the blood is higher due to the intake of medication. But despite this higher dosage in your blood, women have more recurrences. Is this a problem? Yes, this is a problem, because with it, you will be more prone for other things, and I will come back to that later. First, I would like to explain, because I'm also going to show you some of our e-headache diary studies, I would like to explain how the flow of our patients in our hospital is. So when people are referred to our neurology department, we ask them to download an application, as you can see there, and immediately a questionnaire is run, asking about all kinds of migraine characteristics, and an automatic algorithm. We now call that artificial intelligence, but actually it's quite a simple algorithm. Calculates whether you're prone for migraine or not. There's an extensive questionnaire, and then we ask the people to download a headache diary, and that you can see here. And people fill in this diary on a daily basis. And this diary is shown on your own mobile phone, but it's also immediately sent to our hospital, so we can also immediately see what's happening with our patients. And we use this application not only to diagnose our patients even before they enter our hospital, but also to monitoring our treatment effects. Here you can see it in a much bigger scheme. So just to explain it very simple to you, you can see at the bottom, up to above, that those are the days. So 1 month is 28 days in our diary. And you can see that red is not good, so red is migraine. And this is an algorithm that's calculating, so it's not the patient that decides whether it's a migraine day or a headache day, but based on the information that's provided, the algorithm, validated algorithm, calculates is this a likely migraine day or not. And without knowing any further what's indicated there, you can see red is wrong, so you can easily count there are 4 attacks. You can see 4 attacks. You can see in blue is the intake of medication. You can see there's an intake of triptans, this is indicated here, but you can also see there's an intake of paracetamol, of an NSAID. And we indicated some additional features in this diary. We ask a lot of more questions, but these are the features that we and our patients found important for our treatment. How are we going to treat and how are we going to monitor our treatment? Here you can see that this patient changed or started prophylactic medication, and now in practice we can just click on this purple button and we can see what kind of medication this patient took. But I would like to focus on this last part, and this is the menstruation. So we added this later based on the questions of our patients, so we can also see when there is a menstrual bleeding. So now I come to the implications of the menstruation on the migraine attack. So we have a definition when we call a certain attack a perimenstrual attack. And a migraine attack is considered a perimenstrual attack when it starts within this window, -2 days before the first day of bleeding, up to 3 days. So when you have a migraine attack during this window, we call this a perimenstrual attack. And you can see that this patient had 1 perimenstrual attack. Also, we label our patients as having menstrual migraine when these perimenstrual migraine attacks occur in 2 out of 3 consecutive menstrual cycles. So you need 2 out of 3. Surprisingly, if you ask a patient, do you think you have menstrual migraine? It's worthless to ask, because we ask our patients before we started this diary. We asked that to 500 women, and 2/3 said, "I think I have menstrual migraine." And then we had the diary, and about 2/3 were right, and 1/3 were incorrect. And the 1/3 of patients that said, "I don't think I have perimenstrual migraine," 2/3 had perimenstrual migraine, and 1/3 did not have. So, in general, I would say 2 out of 3 women will suffer from perimenstrual migraine attacks, but it's really hard to recall for ourselves, and that's why I think these diaries are very useful. So we notice also that these perimenstrual attacks are of longer duration, and I will come to that later because that's important. What I first want to show you is that there is a difference between migraine with and without aura. So some of you will experience for migraine, sometimes have migraine with aura attacks and sometimes migraine without aura attacks. Here you can see a quite complicated scheme. You can see here, this is the day of the menstruation. And you see there's a peak of, again, if you collect 500 women, you can see there's a peak incidence of the migraine around this window of the menstruation. And this is both true for those with a natural menstrual cycle and those who are taking hormonal contraception with a stop week. So also if you stop during a week your anticonceptive pill, then you will get a migraine attack, as shown here. And this accounts for both migraine without aura patients, MO, and migraine without aura patients. And then we looked into the migraine with aura patients, and we wanted to know within this patient, how is it with the separate attacks? Those attacks with aura and those attacks without aura. And that you can see here. So if you look only for the migraine with aura patients, you can see that there is a peak incidence of the migraine without aura attacks. But for the migraine with aura attacks, there's no increase. So this shows that for migraine with aura, there's something different going on for those without aura attacks. So that's important to know. So there's a difference. And actually you can see this here as well, because this is the aura. I didn't explain, but this cross shows that this patient also from aura attacks, but the attack that she has during the perimenstrual window is without aura. More importantly, these perimenstrual attacks are of longer duration. And with that, there's more need for the re-intake of triptans because there's a recurrence. And you can actually see here, so she treated her attack. It was effective, it's indicated, but the next day there was a need of a new triptan. So you see in this individual patient also the longer duration of the perimenstrual attack and the need for re-intake of medication. So with that, women are more prone to chronic migraine and medication overuse. And it's really important to indicate that this is not a gender issue. It's not a behavioral disturbance in women. It's a biological phenomenon why women are in more need of triptan intake. And with that, it's very logical that women are more prone to chronic migraine, chronification of migraine, and medication overuse. And we should explain that I should not explain it only to you, but also to the doctors that provide this medication. Oh, not sure it's not working anymore. Yeah. Because I think, although there is not a gender issue in migraine women, I think there is, because it's sex-specific that women have more attacks, I think there's a gender issue in the doctors that treat our patients. So I think hardly any male prescribers of triptans are aware of this phenomenon, of this recurrence of perimenstrual attacks, and that we need to focus on that as well. So here you see all the male doctors explaining it to women what they need to take. And you, as patient, have to explain to your doctors what's happening here. So with your doctors, you have to be aware of this problem, and then you can treat properly your perimenstrual attacks. So hormones do not only influence the migraine threshold during the menstruation period, but as you can see, also during the pregnancy. We all know that during the pregnancy, you can see here in yellow that in most women the migraine with aura drops, so you have less attacks, whereas for the migraine with aura it might increase, or you can even experience your first migraine with aura attack during your pregnancy. And the worst period is the perimenopausal period, and the perimenopausal period is the period where your menstruation is fluctuating. So your hormones go all the way up and down, and with that your migraine is worsening most of the times. So to show you that, you can see here two hormones that are implicated, we think, in this process, and one of them is estradiol and the other is progesterone. So you can see that in the menstruation period there is a drop, and I will come to that later, also in estradiol and progesterone, and this drop might be implicated in the provocation of the attacks. During your pregnancy, it all raises, so that's why it's often protective for migraine without aura. And during your perimenopausal period, there's a fluctuation all the time. So we think that migraine can be triggered by the withdrawal of estrogen following a period of sustained exposure. And that's, for instance, the case when you have your menstruation period, or when you take the anticonceptive pill and you have a stop week, or when you are in your perimenopausal period. So what are we trying to do in Leiden? We try to investigate this a bit further. And this is a complex picture just showing that we have collected now 31 migraine patients and 18 controls, and they were followed up for 2 periods of menstruation period, and they had to come to our hospital, as you can see, during their ovulation period. They came 3 days, but also prior to the menstruation period, and we took blood samples to look at the hormonal levels. And as we speak, we had the first measurements of these hormonal levels, and we're going to analyze that the coming weeks to look whether there is also a hormonal difference between migraine patients and healthy controls, but also to see what kind of hormones are fluctuating. And maybe it's not only the estrogen, but also other sex hormones play a role. In the meantime, how are we going to treat women with migraine? To be honest, we do not know. And here you can see all the things that have been used, and maybe you have experience with some of these treatments. So some of these treatments are on the estrogen level, on the right. Some are combined of estrogen and progesterone, and some are only on the progesterone. The problem with all these studies that have been done, it's all small sample sizes. There were no control group. And we must remember, if you have a progesterone-only treatment, there are still fluctuations in the estrogen possible. So that's why we start also to do a clinical trial. And we started this a few years ago. It's really difficult to include patients because there's a lot on TikTok saying there's a lot of information on TikTok by influencers saying that you should or shouldn't not take hormonal treatment, and with that it's quite difficult for us to include young people for this trial. What we are aiming to is we have 2 groups. We have young women diagnosed with menstrual migraine, and we have elderly women with perimenopausal migraine, and we divide those randomized in 2 groups. Half of them get the continuous use of the oral contraceptive pill, and the other half get vitamin E as an active comparator, because you can imagine that you cannot do this blindly. You cannot provide the oral contraceptive pill and the placebo. People will know what they have received. So that's why we have an open label comparative study. This is actually a kind of proof of principle study, just to show whether if you have a stable level of your estrogen and progesterone, whether with that you can prevent migraine treatment. I will not advocate that this is the big solution. What I hope is that with the hormonal measurements, we will find specific hormonal changes. And with that, I hope we can develop a hormone-specific migraine treatment for women with this kind of problems. But as a proof of principle, this study is really important. Why are we doing this study? Because providing hormonal treatment to women is not without risk. So what are the risks? The 2 important risks are the risk for breast cancer, and that's also why we think that when you provide hormonal treatment to women, especially to perimenopausal women, you should not treat them for longer than 5 years. And the other risk is that, as you might have heard, it seems to be a relationship between migraine and stroke. With that, we are very careful with hormonal treatments. So this is not just a candy that you provide to your patients. It's a real treatment, and we should be aware that we have to prove the effect, and we have to be aware of the side effects and long-term complications. So the recommendations for us as treating physicians, but also for you to discuss with your doctor, is that as neurologists, we need to work together with gynecologists. And we have to perform additional clinical trials and also real-world studies to answer this kind of questions. And we have to study the underlying pathological mechanisms explaining this relationship between hormones and migraine. So what are my take-home messages? So perimenstrual attacks are more severe and have a longer duration. There are some treatment guidelines how you can actually help women with recurrences. We add long-acting NSAIDs, or we switch to another triptan. Be aware that women with menstrual migraine are at risk for chronification of migraine and medication overuse. It's a biological phenomenon. It's not a gender issue. The estrogen drop is probably implicated, but the exact pathophysiological mechanisms is still unclear. And oral contraceptives are often prescribed to women with migraine, but there's lack of evidence. And the last message is, mothers, let your children go. Because this is my daughter, and she presented these last few years also a poster. So in the end, it's better to let your child go, and it will resolve after a few years. Thank you for your attention.
Hi. Hello. Hi. Thank you. That was really interesting. We've had a few questions come through, if you don't mind. And if anyone else as well has any questions, if you want to put your hand up or come speak to me, I can read them out for you. So the first one is, can I take HRT estrogen patches low dose when I start menopause despite suffering from migraine? And does it have any positive impact?
Yeah, that's something. So the very honest question is that you cannot provide a good guideline currently on hormonal treatments for migraine. There's no proof for anything. So I see that many women with other complaints, for instance, perimenopausal complaints, they go to gynecologists, and most often because of these other complaints, they start a certain treatment. But there is no proof what kind of hormonal treatment we should provide to women with menstrual migraine, and that's why we're actually doing this clinical study where we have the oral contraceptive pill as a proof of principle whether it will work. Yeah.
Brilliant. Thank you. Someone as well has asked around kind of the links between thyroid issues and migraine, because that's also hormonal based, and whether you have any comments on whether thyroid issues can impact migraine and whether it's kind of linked with hormones as well.
Yeah. So the thyroid hormones, we didn't study it so far as our group. It's also not included in the hormonal levels that we are currently testing. I should look up the last literature about that, but for me, there seems not to be a strong relationship between the thyroid hormone and migraines. So I have never seen strong evidence for that.
Perfect. Thank you. Yeah, that's really helpful. Someone as well has just sent in, so you mentioned about medication overuse and the risk of that with triptans, and kind of what your thoughts are, or have you any experience of people being on GPANTs instead? Yeah.
Very good question. So we know that triptans are risk factors for chronification of migraine. We also know that from beautiful animal studies also performed at King's College with Peter Goatsby and Phil Holland. And we also know from their work that it's likely that GPANTs are not leading to medication overuse, because there are measurements that you can do in animal models as a substitute for that feature. So from animal studies, we think that the GPANTs will likely not lead to medication overuse headache. And also from a clinical point of view, we know that some GPANTs are used for acute treatment, but there are also GPANTs that are used for preventive treatment. So if you can use the same class for both acute and preventive, for me as a clinician, it seems unlikely that it will thus lead to medication overuse. So I'm really eager to look at the results of the G-pens also in menstrual migraine, and I'm really happy that some of the companies are actually trying to set up this kind of trials. And it could well be that this is a very good alternative, especially for women, instead of triptan use. Yeah.
Yeah, I agree. I'm really interested to see as well. I work on the helpline, and yeah, we're getting more and more people trickle through that have tried them, and it's interesting to hear about their experiences.
And maybe to add to that, because we don't have G-pens available in Holland now, but we have the monoclonal antibodies against CGRP. And what we actually found is that if you block CGRP with these monoclonal antibodies, there is an effect not only on the non-perimenstrual attacks, but also on the perimenstrual attacks. So we know from our clinical practice with other medication that block CGRP that it will have an effect on perimenstrual attacks, which is also exciting, I think.
Yeah, definitely. I do have a couple more questions, but does anyone else want to volunteer to ask a question before I do? No, that's fine. I don't want to put anyone on the spot. I just don't want to take over. Okay, so just a more general question then. Sorry, it's disappeared. So someone has just said whether you have any advice on sort of managing everyday migraine triggers, so particularly around lighting, car headlights, things that are difficult to avoid. What sort of your advice around that would be?
Yeah, well, two things. I think there have been some beautiful studies in triggers and migraine that it's better not to avoid triggers. So avoiding triggers may lead to more anxiety and depression, and with that you're more prone to chronify with your migraine. So avoidance might be not the solution for some of the triggers. Furthermore, some of the patients, it's really sometimes hard to distinguish whether you are already into your attack, so you're in the prodromal phase, and you may be craving for certain foods, or you're feeling very stressed or tired, and this is because your attack is already started, instead of that this is in fact a trigger factor. So it's really difficult for patients themselves, and I can imagine that it's really hard to distinguish prodromal phase of your attack and an actual trigger. And that's why we started in Leiden the trigger study, so where we have this e-diary where people can record whether they have headache, non-headache, migraine days, and we added to that a list of trigger factors, and people can also fill in their own trigger factors if they want to have a certain trigger that they want to follow up, but they have to fill it in each day. So there's no bias. And then we can analyze whether there's indeed a relationship between triggers and these attacks. This is really difficult stuff, because this is not one trigger leading to an attack all the time. So take, for instance, the menstruation. Even if you consider yourself a menstrual migraine patient, it can still be that some of the the menstruation period will not trigger an attack. So it's a combination of different triggers. And we are using really cool stuff too, with very clever scientists, to do artificial intelligence, where you combine all these triggers and you look at the personal level whether you can predict a certain chance of getting a migraine attack on a personal level. So for me, it's not interesting anymore to discuss whether wine can provoke an attack. If I say to you, wine can provoke an attack, you want to know, okay, can I never drink wine? When can I drink wine? So you want to know it. You want to know it for you as a person. So we need to have real cool AI tools to make this personal prediction for individual patients.
Perfect. It's like you can see the questions in front of me because you very nicely led me on to the next one. So there's been quite a bit of buzz about these e-diaries from Leiden, and someone's asking if they're open source or if it would be considered in the future that they're made sort of widely available if they're not at the moment.
Yeah, they're currently not open source because it's with the commercial party and we have to pay for that as well. But I think it will be developing, and it might be an open source in the future. And for now, it's really interesting because it can be helpful in our clinical practice, and there are now ways how you get reimbursement as a doctor for the use of this kind of tools. And with that, it will be helpful to bring it further to the public as well.
Perfect, thank you. Yeah, maybe one or two questions left. We'll see how we get on. So there's a few more coming in now. So someone has said those with aura are told not to take estrogen. If you have both aura and non-aura migraine attacks, are you still precluded from taking them? And like risks around that, really.
Yeah, it's also a thing that we discussed on the scientific session, because it's in the classification system that we have developed. We have defined you are a migraine with aura patient when you have had at least 2 attacks in your lifetime, and you're a migraine without aura patient when you have had at least 5. But there are people, so for instance, take myself. I had only 5 or 6 migraine with aura attacks, and most of my attacks are without aura. I do not consider myself a migraine with aura patient, to be honest. But my daughter, due to the genetic factors, we know that children of women with or men with migraine are likely to develop migraine at an earlier age. They are more likely to chronify, unluckily, and they're more likely to have migraine with aura. So she has migraine attacks all the times with aura. So I consider her as a migraine with aura patient. So there is a difference between having maybe 5 or 10% of your attacks with aura or all the time. And we seem not to distinguish this in our guidelines or in our recommendations to women. And I think we should. So it's really difficult to answer, actually, but I think as a rule of thumb, I would say if your majority of attacks are with aura, you should really consider the treatment differently in those women than in those who have a majority of migraine without aura attacks.
Yeah, I agree. I think it's, prompted a really good discussion and debate to be had that probably could go on for hours. Let's have a look. I think we can do one more question if that's okay with you.
Yeah, for me
perfect.
It is.
So someone has asked, sorry, I found. So there's just a more general one, I suppose, to end on. So we get quite a lot of questions about this on the helpline, actually. But is there any evidence for sort of the new tinted migraine glasses, or any evidence behind?
For what?
Migraine glasses. Have you heard about those sort of tinted glasses that go on?
Oh, okay.
Yeah.
So now we're talking about visual hypersensitivity.
Yeah.
Oh, I think that's a really. It's an intriguing topic, but it's really difficult because I think visual phenomena. So we have the visual phenomena when you have an aura. That's very clear, and we know what's happening in the brain with cortical splenic depolarization, etc. So we know that mechanism. Then you have a migraine attack and you have photophobia. So you're disturbed by light. There are different mechanisms involved in that. And then you have people who are also interactively hypersensitive for visual symptoms. And as part of this spectrum, we have people with what's called visual snow. So they have all kind of really strange, I would say, but if you talk to these people, then you recognize a pattern, visual disturbances all the time. And in this spectrum, I think, this is a very difficult question to answer right away. So, and now you ask, is wearing a glass helpful? I would say, as a general rule, be careful wearing dark glasses because doctors will think you're crazy. That's the first thing. So when you sit in the waiting room of a doctor and you want to discuss your migraine, better take off your glasses. Always better. Because they think you're depressed, you're psychotic, etc., etc. So that's the issue of the doctors, I would say. If you feel that it helps you at some times, and some people say it helps when I'm during my attack or just a few hours or days after attack, and then I'm relieved and I can put them away, why not? But now there's a development of certain types of glasses, and there has been some scientific proof about whether the color blue and green can be helpful, and it actually can be, but this will go really far. So Rami Bursin did some work on that. There's also a difference, of course, between the coloring of glass and wearing just sunglasses. So maybe you should use in 2 years a whole day to discuss wearing glasses or not, because there are a lot of people who can say really cool stuff about that.
Yeah, I agree. It's quite an exciting time, isn't it? There's more and more evidence, but it's still quite limited at the moment. Yeah. Perfect. I think that's all I'm going to let you go now. Thank you so much, and thank you everyone as well for all of the questions you submitted. They're great. Thank you.
Okay, thank you.
Excellent. Hopefully we've all learned something there, which was fascinating. Thank you so much, Gisela. We are going to hear from David Kernick next, who is just being mic'd up. And then after that, we're going to have a little break. Please take the opportunity to chat to people, ask them questions. Everyone is here to try and help as much as they can. So find our Migraine Trust funded medics and specialists and feel free to approach them. Even if they don't know who you are, you know who they are. So dig them out and ask some good questions.
Well, thanks for inviting me. I feel a bit like Daniel in the lion's den here at the end of a scientific meeting talking about this thing called healing. And I'm very grateful for the Migraine Trust to allow me to come and talk about this rather controversial subject. You can see I'm not a long-haired hippie, can't you? Although I'd quite like to be one. And I'm not going to talk about crystals, and I'm not going to talk about astrological charts. In fact, by way of background, I do have quite a rigorous background. My first degree was in chemical engineering with an interest in systems theory. I've got a research degree in medical physics. But since 1980, I've been a GP, 1920. Since 1980, I have been a GP, and for the last 25 years, I've run an NHS headache clinic in Exeter. So I might not be a hippie, but I am a bit of a crazy, mixed-up person. So this is what I want to talk to you about, and I want to set this concept of healing within the concept of holistic practice. And I want to deal with a bit of philosophy, a bit of theory, and I think probably what you want to hear about is actually practice. What can it be done? How can it help me? So that's the sort of outline of my talk. Let's start with some definitions. It's really important to know what we're talking about here, and I want to start with some really clear definitions. So it's always good to go back to the Greek for these terms. So holistic comes from Greek holos, whole. So I'm going to take a holistic approach as one that uses different approaches based on different disciplines. Okay, so that's my first definition. What is my definition of healing? Again, this goes back to holos. I'm going to define healing as the body's ability to cure itself. Now, you don't have to go very far to look for that. We're very excited about this new group of drugs that are coming through, and take it from me, they are very successful drugs. But let's just look at some figures here. So this is the first GPANT that's come on the market, and it reduces by over 50% migraine days in 49% of the people. This is fantastic. But people tend to overlook the fact that, when we do randomized controlled trials, we have a dummy drug. Placebo effect, 41%. Now, this is a statistical difference, and everyone says this is great, and away we go, get it licensed and get it marketed. But no one's actually saying, hang on a sec, what's going on with this placebo effect? Why aren't we thinking about unpacking this and utilizing it in addition to the drug? So you don't have to look very far before you can see healing in action. Spiritual healing is a little bit more contested, isn't it, really? And this doesn't necessarily set things in a religious context. Here I'm going to suggest the definition of spiritual healing is beneficial interventions that we cannot measure. Now, you may or may not feel comfortable or happy with that, but that's my starting point to talk about spiritual healing. What about modern medicine? What's the definition of modern medicine? Well, modern medicine is interventions drawing upon scientific principles wherever possible. So let's just unpack what science means. And our starting point here is to see science as an approach that sees the world as a machine. It's a reductionist approach. You can understand systems, the brain, the body, whatever, by breaking them down into their component parts. This has been phenomenally successful. There's a simple relationship between cause and effect. I particularly like the chap at the back who's looking down a telescope. If you don't understand what's going on, all you need to do is increase the level of analytical detail, more research, and the system will yield. The truth is out there, and we can actually obtain it by more and more analysis. It has been a phenomenally successful approach, as we all know. Two problems. First of all, its success, I think, has crowded out other perspectives that may be useful to us. And secondly, I think that, this is what modern science is based on, observation, experimentation. Modern science is objective, without any emotional content, wherever possible using rigorous mathematics. But apart from the danger of crowding out other perspectives, it's leading us into a healthcare system which I see like that. And I think that's a useful metaphor from my perspective as where we're going. And I would ask you to reflect on what I'm asking you to think about with that metaphor for medical services and whether this is the right path or not. So that's a little bit about modern science. Phenomenally successful. It's given us some phenomenally successful drugs. I am a drug doctor, but I want to share with you some insights I've had over my journey over the last 2 or 3 years. So those are our definitions. Let's just think a little bit about background for migraine, general background. So this is where you'll be somewhere on the spectrum. You may have low frequency, episodic migraine, high frequency, or these things tend to transform into chronic migraine. And many of you here will have chronic migraine. And as you increase the frequency of your migraine, so increases the disability. Other problems come on board: fibromyalgia, irritable bowel syndrome, anxiety. I'm sure you all recognize them. Medication overuse, headache becomes more complicated. And there is a suggestion that the more we go into the chronic migraine picture, there may be more resistance to drugs as well. So I think this is how I see the picture. Drugs are really successful. I think they can be really very successful used alone for episodic migraine. As you come into the chronic end, yes, they are very successful, but the problem is they are unmasking other issues that you may be needing to address. At the lower end of the frequency spectrum, the holistic approach might be of some use. I think drugs are useful here, but I think the holistic approach, which includes drugs, gets more useful as you develop more frequent migraine, and particularly in the chronic end of the spectrum. So that's a simple diagram of how I'd like to see things. So some other starting points. It's not your fault that you get migraine. Migraine is a genetic disposition which interacts with environment to form the disorder. Now, some things in your environment you can change, some things you can't, but you can change the way in which you react to your environment. I think that's an important point. You're not alone with migraine. 14% of the population have migraine. It's about number 6 in the world in terms of disability. No cure, but you can control it. And I think this is important. Shift the locus of government. Soon, hopefully, at the moment there's no cure, but I think a lot of people are working towards that aim. And I think the thing that's really crystallized, particularly for me, this meeting, is you have to take back control of your own management. I've been working in primary care, at the forefront of primary care, trying to raise the standards for the last 25 years. And there's been some rather depressing research being presented this meeting that says that things have really not improved at all. And I don't know if you're like me, you see the NHS as unravelling. You may be fortunate living in an area where you have a headache clinic, but they're going to be pretty overwhelmed. I'm afraid the bottom line is you are going to have to take management of your own migraine going forward. And I think the holistic approach gives you the opportunity to do that. Just to go back to this no cure, but shifting the locus of control, this is a nice little metaphorical picture that we developed. We did some research with patient researchers some years ago now, and they developed this little picture. They saw migraine as the beast on their shoulder, always ready to pounce. They were afraid to go out and make appointments because the beast would pounce at any time. So the approach is to get the beast to live in the kennel. When he does come out, be able to put the beast on a lead. But I think with some of these new drugs that are coming through now, combined with some of these approaches I should be talking about, hopefully that beast will be able to stay in the kennel for a lot longer than it has been in the past. But I think that's quite a nice little metaphor. So that's about the reason you have to take back control, and you may well recognise this journey. You'll all be on a patient journey. You've entered, well, 70% of you will have entered the system of some sort. You'll have seen the GP, referred to Neurologist, probably got an inappropriate brain scan, some advice on drugs being sent back to GP. You'll go up to casualty, back to... You recognise this cycle that you're in, this cycle you're on? And there was a really shocking study recently, looked at Western European countries, and they were all about the same, suggesting that only 15% of people will get optimum care. This is in 2024. So this is why you have to take control of your own management, I'm afraid. So let's look at some, that's by way of an introduction, let's look at some basic philosophy. I'm afraid I'm more into the philosophy and the theory of the thing rather than practice, but we're going to cover all three areas. So what is the underpinning philosophy across this spectrum? And it is a spectrum from medical science through to managing our environment, to healing, mind-body healing, to spiritual environment. And things shift as we go across the spectrum. So at the left-hand side, the medical science, the underpinning philosophy is based on Western philosophy and modern science, reductionism, phenomenally successful. As we go across to the other end of the spectrum, we start looking for insights from Eastern philosophy, Indian, Chinese philosophy. And here the world is viewed as a network of interacting elements. What's important is a story that makes sense to the individual. So we go away from big generalizability in collective numbers of people to what is a story that makes sense to the individual. And scientific notions of time and space may not be particularly relevant. And going back to my initial definition, things cannot always be measured. So I think I'm not saying one is right or one is wrong. That is just the spectrum across which we can set our holistic perspective. So the underpinning philosophy is based on the world as a machine. Here, the underpinning philosophy is based on the world as a complex network, and this is a model that's been very influential to me in my career. I was a founder member of the Complexity and Primary Care Group, and there's a big science of complex adaptive systems that you may or may not have heard of, but it starts looking at perspectives that we can gain from looking at systems like that you can't break down, compared with systems like that you can. Now, I'm not saying one is right or one is wrong. That system has been phenomenally successful, but I think this approach can lead us to some really useful insights. So how do we view health across the spectrum? Well, at the left-hand side, health is viewed as a restoration of function, and we've got to fight the disease. He lost his battle with cancer. On the right-hand side, we start seeing health as a harmony between interacting systems. This is where I would probably be starting from, seeing health as a harmony between interacting complex systems, different starting point. In the broader perspective, you'd see health as a harmony between inner and outer environments. I like the ancient Chinese quote that sees health as a dynamic harmony between inner and outer worlds. I really like that. And acceptance, obviously you do what you can, but what you can't do, you accept that which cannot be changed. Now, what's really interesting, these insights are very quickly coming into mainstream NHS practice. If you go and see a pain specialist or a psychologist, you'll be talking about acceptance, non-judgment. A lot of these Eastern philosophical insights are already gaining traction in mainstream medical practice. View of self. Now, this is one could go on all day about this, and this is a hugely contested area. Meaning of life, view of self. So the left-hand side sees self very much set within this autobiography of our lives. Our mind and our thoughts and our emotions combine to form this autobiography which gives our life sense as we look forward to the future. Consciousness is very much a function of the brain, and there are huge numbers of medical science people looking for the origins of consciousness in the brain, and they are yet to find it. I don't think they ever will. The other side of the perspective is that, from the Buddhist takes the extreme perspective, the self is in fact an illusion, and it harms us to develop this nature of self. And we are all parts of a wider collective network in nature. And I really like this insight from Eastern philosophy. This is the Atman of Hindu philosophy. This is the Tao in Chinese philosophy. That consciousness is actually a universal feature of the universe which manifests through us. So isn't that an interesting phenomenon? Isn't that an interesting comparison? So we're very much inculcated in the Western approach, but I think the Eastern approach has got a lot of interesting insights to offer us. So that's some basic philosophy in a nutshell, just to give you an idea of where we are across that spectrum. Some basic theory. I'm afraid we're going to have to get some basic theory done as well before we can get to the nitty-gritty. So why do we actually get migraine? Well, I think this is a reasonable story. People with migraine have hypervigilant and hypersensitive brains. Why do they have hypervigilant, hypersensitive brains? I think we need to go back to when our brain pathways were laid down hundreds of thousands of years ago in the rift valleys of East Africa. And here, if you had a hypervigilant, hypersensitive brain, it would be an advantage to you. You could see your lunch moving in the savannah, or if you were someone else's lunch, you could see them pretty quickly before anyone else. So it was evolutionarily advantageous to have a hypervigilant, hypersensitive brain. But note our environment. We've got nice big wide horizons, soft colours, soft outlines. There's not very much else going on. These are the reflexes we've got in our brain. These are our brain networks. Fast forward a few 100,000 years ago, today, from 100,000 years ago, a few 100,000 years ago, old mechanism, new environment, and you can see why the migrainer's brain gets into trouble. We've got a cacophony of shapes, sizes, sounds, smells, and essentially the migrainer's brain gets overloaded. So what was once an evolutionary advantage has now become a disadvantage in this modern world. So I think that's a simple story to package why you are all in trouble with your migraine. Second bit of theory, which is becoming increasingly important in mainstream science, in fact, is this concept of stress response or allostatic load. So again, these were pathways that were laid down hundreds of thousands of years ago when we were evolving. When we have a stressor, and in those days it was a physical stressor, you'd be attacked by a lion or you'd cut yourself, or there'd be an infection, you set up a response, a protect and repair response, an inflammatory response. This is hugely complex, but we can unpick all this now quite accurately. It consists of activation of parts of your nervous system, and in particular the autonomic nervous system, the sympathetic and parasympathetic parts. Sympathetic is the fight and flight. The parasympathetic balances it. That's the rest, repair, and digest. And in its extreme, parasympathetic freeze. I froze with fear, so you've got the positives and the negatives. These stressors trigger off hormone pathways, adrenaline you're probably familiar with, cortisol you're familiar with, and you can measure all of this. And this hugely complex cytokine system, which has lots of cells and biochemical pathways that repair and defend. So that's a very complex inflammatory response that's triggered by stressors, and we're designed for physical stressors. And here we see the stress response. We get a stressor, the inflammatory response or the stress response goes up and then settles down again. Unfortunately, these days we have multiple stressors in our lives, and gradually this level of chronic stress in our body builds up and up and up. And here are the stressors. They're not just physical, although they can be physical, illness, physical head trauma, we see increased inflammatory load. But we all are carrying around this, if you like, a chronic stress bucket or chronic inflammatory load bucket, which can be filled up by all these things. Migraine is an inflammatory process. Psychological stresses, social stresses, diet, exercise, obesity, and we're getting increasingly interested in previous childhood trauma when the brain is at its most vulnerable. And we're recognizing, in fact, 50% of the population, would you believe, recent studies suggest have a significant adverse childhood event. We're all carrying trauma within us. However, I think I'm fairly normal and straightforward, but once I start unpacking this thing, I've realized through some of these holistic practices that I'm carrying quite a lot of trauma as well. So we're all carrying it. So we've all got this stress bucket of this chronic inflammatory load. So how does the chronic inflammatory load affect the brain? Well, here's the simple story. This chronic inflammatory load increases the sensitivity of the brain, and it impacts upon the control function of the brain. This feeds back again, leading us to more migraine, more psychological, social stresses, which again leads to more migraine, and so off we go in this sort of rather vicious circle. Let's take it one step more complicated. We're now beginning to realize that the brain is not just a reactive organ, it actually predicts. It's a predictive organ. We're always trying to predict what's going to happen, and we minimize our predictive error. Now, we can't take on board all the sensory input coming up from our bodies and from outside. We have to have some sort of modulation. But when we have this chronic inflammatory load, our predictive brain is not working as well as it should do, and it's just like when the radio doesn't work very well. What do? You turn up the volume. So our brain is not working really very well with this chronic inflammatory load, so we just turn up the volume. So we get more sensitivity again, we get more sensitivity to our internal organs, so we start developing fibromyalgia, irritable bowel syndrome. So this is beginning to put together a nice picture of what's actually happening in modern life. If you want to take this one step further again, and you may like to look away now, but this would be my starting point, just to show that there is a fairly hard theoretical fundamental basis to this. I think it's important for me because it helps when I'm in the lion's den to substantiate theoretically the sort of things I'm talking about. I think this offers a really useful model, but this is, for any physicists here, this is Carl Friston's free energy principle, and I think it's useful. You can combine this with insights from complexity theory to really understand what's going on in the brain from more of a standing back rather than a microscopic level. Medical science, this is an approach that stands back, a systems approach that stands more back, gives some useful insights. I'm not saying one is right or one is wrong, I'm saying they're all useful. They're all models. All models are only approximations of how the world is, I think personally, and these are useful models. Okay, you can look back at the screen now. So I'm going to our fourth piece of theory. Mind and body are actually one unit. I think biologists are now beginning to see, or view an approach that it's useful to see the mind and body as one complex system, as an approach, which is quite useful. And we've got an intrinsic feeling for this. This is a study, if you ask people where they actually feel these various emotions. So the blue is where they feel them negatively, the red is where they feel them positively. And you can see that all these emotions are actually felt in the body. We have an intuitive sense. Why do we say, I broke my heart? Why do we say, I have a gut feeling? Why do we say, I feel it in my bones? We have an intuitive feeling that our sense of self is embodied. It's not just up here, it's in our whole body. And I think this is becoming more and more mainstream biology as well. And the other thing, important thing here is this chronic inflammation that we all carry, this chronic stress that we all carry, is not just held up here, it's held in the whole body. And you can see this manifest in heart rate, blood pressure, breathing characteristics, muscle tension, gut mobility, and a whole range of other physiological variables. So chronic stress, or chronic inflammatory load, is held in the whole body. So let's put all that theory together. People with migraine have hypervigilant, hypersensitive brains. We all get overloaded with stressors in our life, multiple stressors, previous and past. These are held in our body. These stressors increase the sensitivity and they impair our brain's predictive ability. This gives rise to further physiological and physical challenge, the way we behave, the way we think about the world. This changes our mindset and sense of self, and all these things feed back again into our hypervigilant, hypersensitive brain. So you can see how we go down this pathway from episodic to chronic migraine. And many of you will be sitting in this vicious cycle. I'm not saying everyone with migraine, but the severe end of people with migraine will be sitting in this system. So let's start thinking about, bearing in mind that theory, let's start thinking about what we can actually do to unpack it. And what I would like to suggest is that we have a model of 4 pillars underpinned by reframing sense of self. Now, this is not for everyone. Clearly, some people are actually very straightforward about their sense of self. They don't have a problem, and they've got a very positive mental attitude to life. But in the extreme, these are the approaches I want to suggest. So the medical approach, the approach of modern science, managing the external environment appropriately, managing your internal environment appropriately, that's somatic healing, and then we can look at spiritual healing approaches underpinned by potentially reframing your sense of self. Let me go through each one of those in turn. So the medical approach asks, do we have the best evidence-based medical treatment? Drugs, other medical devices coming on board, electrical devices coming on board. This is all fairly straightforward. We've got some fantastic drugs, thanks to medical science, which are getting better and better every day, that are revolutionizing people's lives. You may wish to stop there. That's absolutely fine. Managing the external environment. Do I have the lifestyle that is beneficial to my migraine health? We might start thinking about triggers, and just a quick thing about triggers. Don't spend a lifetime looking for triggers. Triggers are complex. If you look at remember that complex system, they're all interacting in a complex, non-linear way. So if a trigger is not obvious, don't waste your time looking for it. Keep your environment constant. People with hypervigilant, hypersensitive brains clearly don't like things that change, so keep everything you can constant. Food patterns, eating patterns, hydration, sleep patterns, all the rest of it constant. This is why females get into trouble with their shifting hormones. Healthy diet. All these things are anti-inflammatory. We know that the worst thing for an inflammatory load is processed food, total disaster. This is all sort of fairly hard medical science, but processed food is a total disaster for an inflammatory load. Healthy diet, you can look on the NHS website to see what that is, pretty straightforward. We all know when we've got a healthy diet, when we haven't got a healthy diet. Exercise is really anti-inflammatory. Lack of exercise is pro-inflammatory. Again, the NHS website is good, but just really do anything. Just any exercise more than what you're doing at the moment is beneficial. It's a really interesting presentation at this scientific meeting. When you have new medication, often you're asking to keep a diary. Well, perhaps a better way of keeping a diary is just keeping your step counts, because as your migraine, it was shown that as your migraine becomes more and more under control, you start moving around more. So step counts might be something you might like to keep an eye on, and then that would reinforce positive behavior. Oh, I must do more exercise. Gut biome is something that's coming on the inside track very quickly. You may have caught up with this, bit of a contentious area, but we always thought that the millions and millions of bacteria that lived in our gut were just there incidentally, and they were just quite happily getting on with their life there. We now realise that they're forming an intricate part of our physiology, and they're really important in the inflammatory mechanisms in our body. So there's a whole big thing emerging around healthy gut biomes. And again, with processed foods, you have disastrous biomes. Interestingly, the best thing for a good gut biome is to get a dog. But unfortunately, in this area, lots of people will sell you things, and there's all sorts of stuff out there with probiotics. But there is a very healthy, again, you can do it dietary-wise, and you can look at what's a healthy gut biome diet. We could perhaps mention that later. But watch out for gut biome. It has been suggested, there was another paper here, this session saying that people with migraine have slightly different gut biomes to those that don't. It's a bit of a controversial area, but it is coming on quite mainstream, and I think we'll be seeing a lot more about gut biome. The other thing that's quite interesting is cold immersion. You may have seen that's also very anti-inflammatory. You needn't go down and have a dip in the sea. You could perhaps just have a cold shower every day. But I take the position, I think I'd prefer to have 3 years less of life than a cold shower every morning, but you need to take a position on that. And unhelpful social environments, you can do things about it. So you do have choices about your social environments. You know, if you're in a relationship that's not good, it's causing all sorts of stress, inflammatory load, you can get out of it. So social environments. So do I have the lifestyle that's beneficial to my migraine health? We then move on to managing the internal environment. And this is really when we start talking about somatic health. And here, I'm not going to go into these in any detail, but here are the sort of things we are talking about. And for me, these are underpinned by some of the theory I have been articulating with you. Listening to our body, yoga techniques, body scanning, meditative techniques. This is all fairly mainstream, becoming into the NHS medical practice. Stillness of mind, non-judgmental awareness, visualization techniques, breathing techniques. There's a lot around the pranayama, the old yoga breathing techniques. Emotional freedom technique is really, really interesting. I would suggest you have a look at that as a way of reprocessing these not abnormal, but unhelpful emotional patterns in our brain. It's all over YouTube. In fact, if you want to look at the Exeter Headache Clinic website, I've got an information sheet and a video on it there, but that's something that NICE has said needs to be looked into in more detail. And then things like trauma release exercises, shaking exercises, all underpinned by a model of chronic inflammation and a predictive brain. So am I supporting my body to heal itself using these techniques, none of which cost money? And then we might like to start thinking about spiritual healing techniques. How can I improve the harmony between my inner and outer worlds? Now, you may think that's nonsense. You may have it all depends how you feel about it, not how you think about it, how you feel about it. And we might start thinking about nature immersion. There's some evidence suggesting that nature immersion, scientific evidence, is beneficial for health. We might start thinking about encouraging social engagement, interacting with other people. We might start thinking about other art therapies, meditative techniques. If you want to go a little bit more pushing the boundaries, you might start thinking about Reiki healing, underpinned for me by complexity theory. And then those 4 columns are underpinned by a foundation of thinking about reframing sense of self. A lot of people with chronic migraine live in the trauma world or the chronic inflammatory load world. They feel, and some of you here will undoubtedly recognize this, you feel ashamed, you feel guilty, you swing between being over-aroused between the sympathetic nervous system and the parasympathetic nervous system. So you swing between over-arousal, hypervigilance, anxiety, panic, poor sleep, chronic pain, and then under-arousal, extreme of your parasympathetic system, depression, fatigue, withdrawal, disconnect, and dissociation. Often people then adopt coping strategies of alcohol and these other things that are not helpful. So reframing sense of self is a other important feature in holistic practice. And these are some of the ways you can start doing that. Mindfulness practice are quite useful. Living in the moment, there's a lot of this stuff about living in the moment. We're all in these chains of how the past and our memories are going to be projected into the future. And we're on these constant changes of, how's the past going to the future, and round and round and round we go, and I'm sure you'll all recognize that. And I think mindfulness offers a really useful way of getting out of those vicious cycles. And then self-compassion is an important one. Acceptance, this is all becoming fairly mainstream. Non-judgmental acceptance, psychotherapeutic approaches. Journaling is really quite important. And coming to terms with past trauma, if you are carrying past trauma in your body, accepting that. I'm not going to go into any detail. I'm just signposting you in this talk. So is my problem influencing how I see myself, and can I reframe that? So just to wrap up, next questions you might like to think about if you want to take a holistic approach seriously. What is the story I'm attached to? Can I change it? Am I prepared to change it? It's much easier to live in the world you're currently living in, isn't it, into your present story than actually change your story. It's much easier. As humans, we want to minimize energy and take the path of least resistance. Can I connect with my body? What is my body asking me? Listen to your body. What is my body asking me? Can I accept what cannot be changed with compassion for myself? Taking action. Can I control and manage the situation in which I find myself? can I accept the challenge of a holistic approach, or do I just want a quick fix? Now, it's really tempting, isn't it, just to take a tablet? Wouldn't we all like to take, I'm taking a statin. I can't really be bothered to go out running twice a day and screw my diet down. It's much easier just to pop a pill. And with these fantastic drugs we've got, it's very tempting to take them, and they are fantastically successful. But when you have chronic migraine with all this other stuff going on, there is a danger that you're not actually addressing what's actually driving the problem beneath it. And it's not easy. Holistic practice takes time, it takes effort. Lots of people fail. You have to go round and round before you actually do it properly. But you need to take a position on that. So these are the key next steps I think you need to think about if you want to go down this holistic route. So that's a bit of a quick overview of how I see it, how my journey has been over the last few years. I'm still a drug doctor, but more and more I'm beginning to attach myself to a broader perspective. What else can we point you towards? Well, these are some books I think are really useful. I really like Eckhart Tolle. You may have heard of him, The Power of Now. He sold millions of books. He's the most popular person in this area of mindfulness practice. I think he's really fantastic. He's all over YouTube. The Body Keeps the Score is the classic book about how our body is holding on to chronic stress. And The Way Out is a book about how you can reprocess the way you handle pain. Two apps are useful. The Curable app is some areas available on the NHS. This is an app that helps you remodulate and reprogram your way you modify pain. If you want to look down the holistic perspectives for all the mind-body techniques, the Insight Timer is a free app which really contains everything you need to know and more. It's got thousands of practices on there, EFT, mindfulness practices, mind-body, you name it, it's all on the Insight Timer, and that's actually free. Curable app costs about £60 a year. The problem is with these approaches is it's all about pain. It's not about migraine. And as you know, migraine is actually more than just pain. But don't worry. Manage Your Migraine holistically is on its way. I'm working with this really interesting person who is a yoga teacher, holistic healer, very experienced. And we've already done 1 6-week course. We're putting together a handbook, which I'm really excited about, actually. It's going to be, I wanted to call it a toolkit, because I like cars, but she said, no, you can't do that. So it's either going to be a manual or a handbook, where we're going to start unpacking all the medical stuff and all these other approaches I've been talking about in a way that's accessible to you. And in the appendix, I'm going to stick away all my theoretical stuff that people can go and look at if they want to. And we're going to make that as cheap as we possibly can. And that will be available hopefully by Christmas. So that could be something for your Christmas site. So if you want more information about that book when it comes out, or any more courses that we're doing together, this is a very basic, we haven't got our website together, and that's a really naff site at the moment. But you can put your name down there and we'll contact you if we have any more courses or when the book comes available. If all else fails, we'll put that on the Exeter Headache Clinic website and you can access it through there. But that is a bit of a, we're not quite there yet. But you can access expressive interest there. Good, that's me finished. So I hope that's been of some use to you, giving you an overview of what holistic practice is. You know, we're living in a very fortunate time with migraine at the moment. We have some fantastic drugs that we can draw upon. And in many cases, drugs will be the whole answer. But I'm suggesting that if you have chronic migraine, with all the other stuff that goes with it, and take it from me, as I'm sure you're aware, there's a huge amount of stuff that goes with it. You may need to start thinking a little bit more broadly about how you wish to address your problem. Okay.
Thank you. Thank you so much, Dr. Kernick. That was really interesting to see all the sections and how to split it up. So we've only got time for a couple of questions, if that's okay. Yep. So the first one, and a few people asked this actually, is around the exercise and can be very helpful for migraine, but for some it can actually be a trigger as well, or maybe inaccessible. What would you advise?
You're going to be sensible about this. If migraine's exercise can be a trigger for migraine, and if you have a migraine attack, clearly exercise can make it worse. You're going to take a pragmatic, sensible approach, haven't you? If it makes your migraine worse, you can't do it. And it's only one of the whole sort of package deals, so it's not always possible.
Are there any sort of more low-level or helpful exercises people can do if it is a trigger that might be helpful?
Just doing anything. It's been shown that doing anything is beneficial. So rather than just turning the telly off like that, why don't you just get up and turn the telly off? So just simple little things like that can be very helpful. So anything you do is a step in the right direction, even if it's getting up to turn the telly off rather than pressing the button.
Yeah, and things like stretching. Yeah, perfect. How do you feel about acupuncture? Do you think it can be helpful, and is it something
100%. Acupuncture is actually looked at by NICE. I was on a NICE guideline group, in fact. We looked at acupuncture, and it's a bit of a contested area, but the evidence is there for acupuncture. The problem is there's lots of different types of acupuncture. And if you want to look at the theory of acupuncture, it sits within the spiritual practice, because that's all about energy flow, which sits probably, I would think, in the spiritual side of things. We can't measure it, but the trials suggest that it is beneficial. It's not. It should be available on the NHS because NICE has recommended it, but you won't find anywhere that will actually give it to you. So yes, acupuncture can be beneficial.
Yeah, that was the follow-up as someone asking if, it's available on the NHS.
Well, it should be in theory, but like everything else, there's a gap between what's theory and what's...
Yeah, perfect. Similar question, but around devices as well, like non-modulation devices, things like that.
Devices are not available. The vagal nerve stimulator is available if you've got cluster headache, but devices currently are not available on the NHS. You have to buy those.
Perfect. Yeah, exactly. In terms of diet and things, we get a lot of questions about this on the helpline as well. Is there such thing as a migraine-friendly diet, or is it more about the individual?
It's a controversial area. I mean, there's lots of people who will take money off you trying to get your sensitivity to certain foods. There's no evidence that there's a food. There's obviously food triggers, but there's a bit of evidence around. There are certain diets that are helpful for migraine. The ketone diet. The high or low sodium diet, there's a bit of evidence for both, but the evidence is not great, but there is some suggestion out there that there is such a thing called a migraine diet. You may wish to try it and see if it works for you, but the evidence is not strong. I think the most important thing is to have an anti-inflammatory diet, keep away from processed food, and eat sensibly, fruit, vegetables, non-processed, lots of high fibre.
Perfect. Yeah, exactly. Thank you so much. So there was another question on we've asked quite a few. There was a lot of buzz around, just kind of what you were saying in terms of healthy lifestyles and things like that. Is there something that you think is... There are a lot of questions asking what the most important thing in terms of a more holistic approach, kind of what thing stands out of the sections that's the most important? Is there...
I think the important thing is there's not one big thing that stands out. It's a shift in the way that you run your life. And it's no good saying, cold immersion is more important than this. It's a package. It's a sort of soup. You're going to move to more of a healthier soup, if you like. So I'm not going to say there's only one thing that stands out amongst anything else.
It's in the name, isn't it? Holistic.
They're all important. It's a holistic
together.
thing. Yeah. It's a complex system of interacting things. And one of the things that complexity teaches you can't actually always pick out. You can't actually reduce it to its component parts and say that's important, because when you do that, the whole system breaks down. So I would say all these things are interacting in a complex manner to your benefit.
Yeah, exactly that. Any other... Okay, there's one person who has a question, and that will be our last question, then we'll let us go for break.
I've got a microphone coming for you.
Yeah, thank you, Chris Hinchy. Something you said just now about diets and so on made me think, is there any evidence that different regions of the world may have higher or lower migraine prevalence? For example, Mediterranean diets, Asian diets and so on. Is there anything that links?
It's very difficult, just on that spectrum, as medical science shifts across as it goes through environment, it's really difficult to pick out, because there's so many interacting factors. You could say they're better in the Mediterranean because they get more sun, so they get more vitamin D. So it's very difficult to pick out what's important, what's not important. And I don't think you'll ever answer that question because of all these confounding variables for other things that are happening.
Okay.
Yeah?
Thank you.
Thank you. I think, that's it. Thank you, Dr. Kernick. That was really interesting.
Thank you.
Thank you.